to introduce Professor Michael Papadakis to speak on putting screening into perspective, what screening cannot do. Michael, the floor's yours.
Thank you very much. So you had an introduction as to what screening can do, and then my role was to potentially outline some of the limitations, because there is no doubt that every screening program has limitations. To be honest with you, I will do that predominantly by describing our experience with cardiac risk in the young. And I've got two examples. One is the Football Association screening that Sanjay and Anil led, and the other one is the general population screening that we do with the charity. The first thing I wanted to highlight is that although sudden cardiac death usually comes to the front when there is an elite athlete or someone who is very visible and famous has a cardiac arrest, the reality is that it affects all young people, and it affects all young people whether they exercise at high level or not. And obviously that's the mindset of the charity, and that's why this charity offers screening to all young individuals between the ages of 14 to 35, not only elite athletes. In terms of screening, there is an issue because it's not just a single condition that we're looking for. We're looking for many different conditions, and depending on what data you look at, different conditions are quoted with different prevalences, okay? This is a study from collegiate athletes in the United States, but overall, there are inherited conditions such as cardiomyopathies and ion channelopathies. There are the connective tissue diseases such as Marfan syndrome. There are congenital conditions such as coronary artery anomalies and accessory pathways like Wolff-Parkinson-White. We've got acquired heart disease such as myocarditis, as Dominico said, atherosclerosis in the older athletes. And then sometimes you can have a cardiac arrest, obviously in the absence of cardiac disease such as commotio cordis or other metabolic abnormalities. Now, the aim and the notion of the screening that Professor Corrado mentioned earlier is essentially the fact that you have someone who is predisposed. 80% of individuals who exhibit a cardiac arrest, they never had a symptom and they never had a family history they knew about, so they didn't have a chance to go and get evaluated. And this is based on a health question, a physical examination, and 12-lead ECG. The reality is that the 12-lead ECG is the core of the cardiac screening program because it will detect most of the electrical abnormalities, and it can also be quite effective in detecting structural abnormalities such as cardiomyopathies. The way we do it with cardiac risk in the young is it's not only young athletes, as I said, it's all young individuals between the ages of 14 to 35 that they wish to be screened. We did recognize the value of the ECG, and the ECG is really the core of our screening program. Yes, there is a questionnaire, and Hamish McLachlan will refer to it later on, which asks about symptoms and family history because it's still important, but the examination has a very minor role. And we do have an echocardiogram on site for people who have an abnormality, and that's predominantly to avoid an increased number of referrals or to offer some reassurance to individuals who have, let's say, lateral T-wave inversions, that they don't have a massively thick septum and need to be seen on an urgent basis. And obviously, the other thing is that we don't disqualify individuals, particularly in the United Kingdom, but it's about thinking for exercise prescription, and I think that's a very important message. And the reality is that cardiac risk in the young does that screening for the entire United Kingdom, and you can see that we go as north as we can possibly go to as south as we can possibly go. We use supermarkets, we use hospitals, we use vans, we do screening in all different venues, and our fellows have to travel up and down the country. Now, what are the challenges of cardiac screening? Many different conditions, as I said, and some of them are extremely complex. The questions about the effectiveness of the 12-lead ECG as a screening tool, usually people concentrate on the false positives, but as Domenico explained, we have worked on that, and the false positives have come down quite significantly. So I will focus a bit on the false negatives. The management of individuals with inherited cardiac conditions, as some of them are quite challenging, and for some of them we don't quite understand the natural history. The available resources and expertise are a very important issue, as well as the associated costs. And as I said, I will focus for this lecture on the false negatives. So if we go to the first study of the Football Association, they screened their grassroots football players. So here you've got screening of individuals of more than 11,000 young adolescents with a mean age of 16, predominantly male. Now, FA, as you probably know, they've got more money, so in terms of screening, they add the echocardiogram on top of the questionnaire, the physical examination, and 12-lead ECG. And they do identify conditions, about 42 individuals, so that will be that 0.3%, 1 in 3 to 400, that you will hear repeatedly from different studies. And you can see that it's a mix of cardiomyopathies, angiopathies, accessory pathways, and with the echo also they had valvular disease and significant aortic dilatation that required surgery. The most useful screening tool is the ECG, followed by echo, and then history and physical examination. And because an echo was performed, they identified also a significant proportion of individuals who had the bicuspid aortic valves, the mitral valve prolapse, which are not necessarily going to kill you during your football career for most individuals, but we know, for example, that a third of people with bicuspid aortic valve will develop significant valvular disease requiring an intervention in their 40s and 50s. During a follow-up of about 11 years, there were 8 cardiac-related deaths despite the screening, which gives us an incidence of 1 in 15,000 athlete years, or 1 in 15,000 athletes per year, which is completely different to 1 in 15,000 athletes, okay? It is per annum, and it's important to keep that in mind. In terms of causes, you will see that most of those deaths were due to cardiomyopathy compared to other data that we have presented of the normal post-mortem heart predominating. So obviously the screening did not identify those individuals, and it's worth highlighting 2 individuals who were identified with hypertrophic cardiomyopathy, but they continued exercising and then they experienced cardiac arrest, which I think brings to the fore the fact that we have certain limitations in terms of appreciating the risk with those inherited conditions. What about the screening of the general population? This is a lot of sweat and tears have gone into this work by Hamish McLachlan, and we've got data of 104,000 young individuals. Only 10% of them were elite competitive athletes that were screened as part of their team. They underwent the screening that I described, so they filled the questionnaire, they had their ECG. If necessary, they may have had an echo, but only a small proportion of them, and then they had a consultation with our cardiology fellow. And the important aspect of this research is that usually we focus on those who had a positive screening result. Here, we went after data for everyone, okay? So we wanted to know the ones who tested positive and the ones who tested negative, and we were able to get data in 98% of the cohort. So we had data from national databases in terms of deaths and conditions. We had 25,000 individuals who responded directly to our request for more information, and we had data that individuals submitted to the charity after they got screened. What were the outcomes? Well, 2.5% had a positive screen, and out of them, again, that 0.3% were diagnosed with a cardiac condition potentially associated with cardiac death, including, as you saw before, accessory pathways, cardiomyopathies, channelopathies, so on and so forth. And very, very importantly, I think that 40% of those individuals received an intervention beyond lifestyle and medication, whether that was an ablation, whether that was the implantation of a defibrillator or a pacemaker, and 2 individuals received cardiac transplants for heart failure. What about the individuals who screened negative? And that was the great majority. Within a 4-year of follow-up, or an average of 4-year follow-up, they then presented with a potential condition. So that was 86 individuals, or 0.08%. Now, so key messages from this study is that 1 in every 40 individuals screened had an abnormal screening. 1 in 10 referred will get a diagnosis, but also 1 in every 1,200 that was cleared received a diagnosis at a later stage, so screening identified about 80% of the condition. However, of the individuals who were missed, there were also 35 individuals who experienced a cardiac arrest or a sudden cardiac death, and you'll see they're almost equally split. So if you're reporting the incident of sudden cardiac death, you probably miss the other half who survived the cardiac arrest. And that makes the incidence in this particular cohort 1 in 18,000 person years, which is not that dissimilar to what you saw in footballers. Threefold higher in males compared to females, and no difference between athletes and non-athletes. And I promise you that we went back to 29 out of the 35 ECGs, because 6 of them were flagged by the screening, but there were different circumstances why they didn't get a diagnosis or why they get the diagnosis. But 29 who were cleared by the screening, we went back, we looked meticulously at those ECGs, and we couldn't identify the faults with those ECGs. So let's discuss some of the challenges. As I told you, there are conditions that screening simply cannot identify with a 12-lead ECG. CPVT is a good example, coronary artery anomalies, so on and so forth. We also have to admit that screening will not identify a proportion of cardiomyopathies, and the same is true for some of the ion channelopathies as well. So you cannot expect a screening tool to identify all of those conditions. The other thing to highlight is that there are challenges of our understanding. So here you've got 10 individuals in the black pie chart, part of your pie chart, who had a screening, it was negative, they died. Most of them had a post-mortem, it was normal. We screened the first-degree relatives and still we're not further forward in terms of what exactly happened to them. So we assume that it was some sort of arrhythmic death that we attribute to sudden arrhythmic death syndrome. And then what can happen occasionally, you've got an individual with WPW at the age of 16, gets referred, he gets reassured because he hasn't got symptoms, he gets discharged, and 4 years later he ends up with a cardiac arrest. So the other thing to address is what Domenico said about age-related penetrance, because I told you there was at least 4 years between screening and being diagnosed with a condition. And we know that of the individuals that are screening identified with cardiomyopathy, they were 4 years older compared to the cardiomyopathies that were missed by the screening and are identified later on. And this is a very nice example of a rugby player in 2008. And look at his ECG 4 years later when he was diagnosed with hypertrophic cardiomyopathy. And I have no doubt that the artificial intelligence will further enhance the power of ECG screening. And we've got already evidence for that in terms of diagnosing low QT or hypertrophic cardiomyopathy, and Dr. Bhatia will refer to it in the next lectures. So take-home messages: 1 in 300 young individuals screened will be diagnosed with a condition that may be associated with sudden cardiac arrest or sudden cardiac death, and 40% of them will have a procedure to try and prevent that. For me and for cardiac risk in the young, screening is about prevention and informed decision-making. It's not about exclusion from sport. We don't do a favor to screening if that's what the notion is. ECG is by far the most viable screening tool in our practice, and I'm sure that the advent of AI will further enhance its performance. You need to do it well, and you need to have the experience. It's not an easy job. And the other thing is you have to remember that screening is only part of cardiovascular disease prevention, which includes evaluation of high-risk individuals, those with symptoms, those with family history, as well as emergency response planning. Thank you very much for your attention.
So thank you, Michael.